All right, doctor, go ahead.
But I can move, right?
Yes.
I'm not planning to stay here.
Nope, you can move. All I'm doing is taping the, yeah, because I'm not going to go.
Hello again. Good evening. I'm Namita Dhiman. I am one of the Child and Adolescent Psychiatry Fellow. I have done my residency, General Psychiatry Residency at UNMC in Creighton, and I'm doing my fellowship right now. And this is my final year. And for whom I have already told that I'm in a process of interviewing, so this is my last year of doing so many things. Right now I'm at Emmanuel Hospital doing inpatient in the morning, and afternoon I do clinics at UNMC and Creighton. So, you know, I was telling them before you all joined us that anxiety disorder, I've seen so many patients with anxiety disorder. When I got this email from Dr. Brennan and from our department that they need a presentation and child psychiatry, if we have anything to present, the only thing came to my mind was anxiety disorder. Because this is one of the disorders that is very uncommonly, you know, either overdiagnosed or underdiagnosed. So, anxiety disorder. Before I start the presentation, I'm gonna ask a few questions, and I'm gonna present 2 case scenarios. And we can discuss about these 2 cases later on, and you can ask me anything in between. So first case, a 6-year-old male child referred by a primary care physician because of shyness, inhibition, and especially when he recently entered the school. Difficulty separating from the parents, started acting out, frustrated, angry, irritable for some reason, and now he started getting, he was potty trained, toilet trained, but now he's bedwetting at night, nightmares, waking in the middle of the night, and screaming, and then cussing his parents. Then the second case scenario, 11-year-old child, very smart, above average intelligence and high intellectual functioning child, very popular in the school. And recently, the school, he has just found the level of work has increased in the school because of the complexity of the school work. His report card, he used to be an honor student. Now his grades are going down, C's, D's, and he's also failing some of the grades. So he went to the primary care physician and they referred this patient for psych evaluation. The school has already done the psych testing just to evaluate whether he can really tolerate this burden of the complexity of the school and the level of work that he's doing and he's supposed to do. So they just wanted to retest whether he needs any special services in the school. So they found that, oh, he's high IQ child. And then they found out that he started developing, parents are saying that he started developing depression. And then he was referred to us for evaluation. So far, any questions, anything about these 2 cases? Any opinion? What do you think what's going on here?
I mean, they both have anxiety.
Right. And so, most of these kids, sometimes when parents or teachers are complaining their poor academic performance, and when the parents are complaining they're worried about the depression, they're worried about irritability, anger, and frustration. These are the most common symptoms when they are coming to the clinic. And so what happened, the underlying symptoms, they usually say, inattention, they are not paying attention to the class, and because you don't like the schoolwork. And the other child, the smaller one, the 6-year-old one, he's acting out, very hyper in the class, doesn't want to sit in the class. So, sometimes ADHD, oppositional defiant disorder, and there are so many, a long list. ADHD is most commonly overdiagnosed disorder. But when we do these evaluations and just a screening, questions, so they usually have anxiety disorder. Like in the first case, the 6-year-old one, he has this separation anxiety disorder. And someone was telling me, Becky was telling me that separation anxiety, how frequent separation anxiety you can see in the kids. And then in the second case, 11-year-old, he came out with generalized anxiety disorder. And generalized anxiety disorder is so debilitating in kids of this age, adolescent population, that sometimes they have comorbid depression. And they are coming with suicide thoughts and depression, and anger, frustration, all those symptoms, but nobody's covering the underlying, most common symptom, that is anxiety. So, these are very frequent scenarios we find in our clinic, and it's sometimes we are kind of stuck what to do with these kids. How to start, which symptom to treat first. So now I'll try to talk about anxiety. So children with anxiety, especially they cannot speak out that they have anxiety. So the term refers to the dystonic mood such as fear, worry, and apprehension. It is generally experienced in reaction to specific fearful stimuli. Do you think we all get anxious? I was anxious before talking in front of you all. So we all have anxiety. But what is an anxiety disorder? And what is anxiety? We all have normal anxiety. So do the children, so do the kids. They have normal anxiety. So it's a normal phenomenon. Anxiety is a normal reaction to stress. But when it is called as a disorder, when it is excessive and prolonged, the experience of anxiety can stop being adaptive and become a source of distress or impairment. And significant dysfunction you start seeing, we all see dysfunctional, the kids are socially, disinhibited or inhibited, and significant problem in different areas in school, home, and socially with peers. So that is the anxiety disorder. So the symptoms of anxiety, in general, the symptoms of anxiety are psychological and physical. Psychological are feeling tense, feeling on edge, inner unrest. These are the three things I always ask my patients. And then physical or somatic symptoms, dizziness, tightness, and it can be head to toe, any symptom. And dryness, choking, oral dryness and choking sensation, disordered breathing, palpitation, funny sensation, tremors, sweating, diarrhea. It can be any symptom. They can come with pain, just a random pain, extreme anxiety and then pain. Variation of anxiety with age. So as we were talking about normal anxiety, so kids have normal anxiety. Infants have strangers anxiety between the ages of 7 to 9 months. Lots of studies done, just to prove that this is how to differentiate whether this is normal and when it becomes abnormal. So up to, the studies have shown up to 7 to 9 months, strangers anxiety, that is normal. Toddlers have separation anxiety between the ages of 12 to 18 months. That's normal. And I'm going to explain more about the strangers anxiety and separation anxiety later. Adolescents' manifestation of anxiety varies with the cognitive capacities and increase in social and personal expectations. Because now the small little brain is growing up. Now their cognitive capacities, their executive functioning are, they're developing those. And now they can be more dysfunctional if they cannot deal with the stress and anxiety. So, first, about the separation anxiety disorder. Excessive anxiety of concerning separation from a loved one or, your attachment, any attachment feeling, and possible risk of development of panic disorder or agoraphobia in adulthood. So now why we are saying separation anxiety disorder? Because now it's not in the age 17 to 18 months or 19 months, it's beyond that. And it can be seen in adolescent population, and in adolescents it's most commonly seen. But I'm going to talk about it can not just solely present as separation anxiety. It can be associated with other anxiety disorder too. So school refusal is very common in kids with separation anxiety disorder. School refusal. Sometimes parents, they bring the kids, just they're refusing to go to school. There's nothing happening in the school, no bullying, no teasing, no issues at the school, but they don't want to go to school. And then they're saying that it's their own anxiety, they don't want to go to school because, you know, there is some hidden anxiety from, it's keep on going and it's accumulating, and then later on they're refusing to go to school. And they come up with the reason, no, there is bullying and teasing, and then we usually, you know, as a provider, we talk to not only the patient, parent, but the school counselor, teachers, everybody, just to get the collateral information. What is this exactly about? You know, before diagnosing a child with exact specific anxiety disorder. So when anybody is coming with to me with anxiety issues, and I'm not sure what kind of specific anxiety it is, I'll say anxiety disorder, not otherwise specified. That is, you can see, you know, most of the time if we are not sure about the anxiety, we say anxiety disorder, not otherwise specified. So in this separation anxiety disorder, the condition must last for at least 1 month and be source of significant impairment. Onset typically occurs after the age 6 years and before 18. And I said before, school refusal is very common in separation anxiety kids. Social phobia, also known as social anxiety disorder. Persistent fear of social or evaluative situations, performance, speeches, meetings, and social gatherings. If I'm a little bit anxious about before presenting, it's fine. But if I'm tremulous, you know, throughout the presentation, and I need a beta blocker or something before my presentation, then I especially, then for sure I'm gonna have this social anxiety disorder. I didn't take any beta blocker today. So, behavioral inhibition may be temperamental predictor of social phobia in childhood or adulthood. I'm going to talk about that thing that I've written on that board later on. That is because anxiety has a very close relation in kids who has temperament issues, behavioral issues, and coming with just bad temperament. So I'm going to talk about that later. Somatic symptoms may be present. In toddlers, any anxiety disorder may or may not have the somatic symptoms, that is physical symptoms that I have mentioned before. That's why I just wanted to mention about general, you know, in general, just the anxiety disorder. Because in DSM and DSM criteria, the generalized anxiety disorder, it has different criteria. But in all the anxiety disorder, we'll see that physical symptoms may or may not be present. And in toddlers who are behaviorally inhibited, it's important to differentiate autism and related disorders. Very important, because I do have some cases in my clinic that child was not talking, and I diagnosed him with selective mutism, that he was not talking in the school. Mom was saying he was talking at home, 4-year-old child, and mom wanted me to give the medication. I said, I'm not going to give the medication before I just make sure that what exactly is going on with this patient. So I started seeing this patient every week. This is a 4-year-old, so cute. I mean, the only thing he was doing was sitting on the chair and smiling at me. And then I started, you know, using this, just some kind of sign language, my naive sign language, you know, with pictures and cartoons, and he was just nodding, he started nodding his head. Then the mom was saying, no, he speaks a lot at home. It's not just at school. So I was kind of whether to do a psych testing and to refer him to Munro Meyer Institute, whether there's some autistic things going on, but why to waste so much of resources? Let's screen the patient first. Then I talked to the teachers. Teachers were saying he's not talking at all in school. Then I told mom, okay, can you bring some videos from home so that, you know, I can see when you're saying he's talking, how exactly he's talking. I don't know, because I'm not sure, school is not sure, what is he doing at home. So mom brought the videos, oh my God, jumping here and there and using all the words, and he was angry at mom for some reason, and then mom said, this is what he's doing. And at home he was extremely angry, using cuss words, and then later on I came to know that patient had speech disorder in the past. There is significant history of speech disorder in the family. But before referring to autism or anything, I referred him for behavioral therapy in Boys Town. And after 4 weeks or 5 weeks, patient started saying hello to me. and he started doing, he started saying good morning and started doing his work very well in school. So I was working with school and his behavioral therapist, but mom still wants to bring him to the clinic. He's not on any medications. He's doing very well. And but it is very common that we do, misdiagnose these kids with autism. And autism is more than autism. Nowadays, Asperger is very common in the market. Parents come and they say, he's so Aspergerish, and he's so odd. He's not talking, and he's just into himself, and he's so Aspergerish. So before we diagnose anybody, I think we should rule out the underlying any anxiety issues.
Have you found that in high functioning autism that anxiety is also very prevalent in that population?
Absolutely, comorbid. Yeah.
I have a 19-year-old son, and that's his biggest issue with his autism.
Autism, OCD, tic disorder, they have very close relation. OCD is a type of anxiety disorder, and autism is very comorbid with OCD. But what I'm saying is, before we jump to autism, if we try to just rule out if there is anxiety or not, just screen for the symptoms, because once the child is autism, I'm just from the insurance point of view, I'm saying that now the parents will be coming for, oh, he's autistic, he should be on disability and all that stuff.
As parents, we noticed the anxiety long before we came to the autism.
Okay. So autism is comorbid with anxiety and OCD too. And then generalized anxiety disorder. So it's excessive, uncontrollable worry about multiple issues. At least one somatic complaint for sure. Close genetic link with depression. And somatic complaints are variable and can include the usual array of anxiety-related symptoms. So the 11-year-old that I presented to you who had, because of the increased burden of the school, it can be any stress, but generalized anxiety disorder may lead to, maybe very commonly comorbid with depression. So sometimes, and it is also very commonly seen in adolescent population, that they are worrying about one thing and they started worrying about different things, but it starts with one thing, So I think behavior modification and to address the cause there and then, prevention is much better than cure. So if we try to address one issue, it is not going to get complicated. So 20% of the children with anxiety disorder also exhibit attentional and conduct problems. And these kids, any anxiety kids, these are usually perfectionists, and their distress is much more than what is evident to parents. Usually, kids are very good in covering their symptoms. They're not going to tell you that they have anxiety. But it's the parents and the caregivers. They need to observe if they are observing any changes, and they need to notify the primary care provider if there is significant, if they are seeing any changes, that child is now inhibited, withdrawn, and they are seeing any dysfunction at home or at school. Because otherwise, child is not going to come and see, unless he's failing the grades or he's not, going with his peers, and he's not, he's kind of dysfunctional in his society. So parents, teachers, they should keep a watch. Specific phobia, extreme fear of specific situations or objects. To make the diagnosis, their condition must be present for at least 6 months. So for specific phobia, they have divided into, you have a question?
Nope.
They have divided into different types of specific phobia related to the animals, natural environmental phenomena, blood injuries, specific situations, and residual category. But how to ask the questions? Usually, when I ask the child, do you get scared, extremely scared from dark, or, something. It's age-specific question is very important. If we are seeing kids of less than 6 years of age, if we are asking this question about are they getting scared of dark, it's very common. They are getting scared of dark. It's very common in that age. But if it is, making them dysfunctional, they are even scared during the day. They are scared to go in the hallway that is little dark in the school. Then it is, So we need to make our judgment clear there. What is dysfunctional and what's normal? So panic disorder with or without agoraphobia. Unexpected panic attacks accompanied by worry about future attacks. Agoraphobia is diagnosed if individual avoids places in which escape would be difficult or embarrassing. Panic attacks can be caused by medical conditions, hyperthyroidism, cardiac abnormalities. No triggers, sometimes unexpected without cues. So panic attacks can be cued or uncued. If the panic attacks are uncued, then they are mostly panic disorder. But if they are cued panic attack, that can be in other anxiety disorders. You know, like they start feeling anxious, and then they have a panic attack, extreme panic attack. But in panic disorder, it will be all of a sudden, without any reason, they are feeling panicky. So that is uncued panic. So then that differentiate between the panic disorder or panic disorder in other conditions, you know. Because any patient in panic disorder, we see so many times in the ER, patients coming with just panic attack and they felt like they are going to die. So what do? Medical workup. And when they do all the medical workup, everything is done, then they call us to evaluate for the panic attacks. And we, you know, just for the insurance purpose, whether what we are going to write, anxiety disorder or it's a panic attack. So panic attack is usually uncued. And then I haven't listed the number of symptoms. Usually from the DSM criteria, there should be 4 out of 13 of the physical symptoms like hyperventilation, palpitation, and dizziness, they will die. And so 4 out of 13 symptoms for the panic disorder. And selective mutism. As I have mentioned about one of my own clinical case about selective mutism, I wanted to mention it here too. They used to call it elective mutism because child is not mute in all the situations. He's electing to be mute in one situation. So deliberate choice rather than emotional difficulties must rule out speech and language disorder or psychosis. And also when we are ruling out speech and language disorder, because speech and language disorder have genetic predisposition, so there should, we will find that in extended family, in maternal or paternal side, if there is any speech or language disorder. Differentiate from autism and pervasive developmental disorder, and behavioral approach as a first-line treatment. So also kids with selective mutism frequently have social phobia. Also sometimes they come with school refusal. If they have selected older kids, they come with school refusal. They don't want to go to school for some reason. And the best thing to do in selective mutism is, if you're not sure it's selective mutism, you wanted to make sure, just tell the parents or the teachers if he's, for the audio or videotaping the child's behavior or whenever in any situation he's talking. So that, he's not completely mute. We don't have to do any medical workup. It's selectively mute. So normal, just to substantiate the normal speech and language in one setting. Epidemiology. In general, anxiety disorders are as common as mood disorder in children, affecting 1 in every 5 children. 3 to 30% of the children in community samples. That's why I mentioned in community samples, because in the anxiety practice, according to the American Child and Adolescent Psychiatry Association and the anxiety parameters from 2007, it says up to 20% or 25% of the children in overall samples, in the in general population. But they have noticed in the community samples, 3 to 30% have, it's more anxiety disorder is common. All forms of anxieties are more common in pre-pubertal females, with exception of generalized anxiety disorder, which is more frequent in adolescent girls. Actually, recently I took my boards and I had this question in my notes. Again, more about epidemiology. Onset of separation anxiety disorder is earlier than other forms in pre-pubertal girls. Frequency decreases over time. Social phobia is more frequent in adolescents. Lower socioeconomic status is associated with specific phobia and normative fears. One anxiety disorder, that is very common, like if one patient is coming with one specific type of anxiety disorder, for example, generalized anxiety disorder, we have to definitely rule out he must have or if that is not treated, the most common risk he is at to develop the second anxiety disorder. So one anxiety disorder is commonly associated with the other anxiety disorder. If two or more anxiety disorders are not treated, then patients are more prone to develop more disorder in the form of depression. Then etiology, genetics, psychosocial. So I have developed this biopsychosocial model. I have tried to mention a little bit about genetics. Increased risk in children with family history. Higher rates of concordance in twin studies. And 5-HTT, that is the serotonin transporter gene, has been implicated. So that's why kids with anxiety disorder have close relation, or they are more prone to get depression too, because it's the same gene that is contributing for causing depression too. If you look back at that whiteboard, so genetic influences. So if we start with the genetic influences, they causes fear and they affect the fear and the reward circuits of the brain. There is in inner part of the basal part of the brain, there's amygdala, and there's then the frontal part of the brain, prefrontal cortex, are mostly affected in anxiety. Then it is further affected once the little small child brain is developing. It is affected by the environmental influence, and that further affects the social maturation because brain is still developing. It is further affected by the core psychological processes going on. Social maturation and attention is affected. That further leads to broad behavior tendencies, anxiety disorder, temperament, adolescent changes in social relationship. Very common. Modeling. If any parent has anxiety disorder, that child, even if there is genetic association, fine. But environmentally, and if the child is living around that parent, modeling, he's learning those behaviors. If the mom is saying, oh, I'm anxious, child, rather than to deal with the stress, next time is going to say, oh, I'm anxious. So when we are saying, what do you mean by anxiety? Sometimes kids are not able to differentiate what anxiety, what they mean. But they have heard this term from parents. So modeling, behavior learning by observation, is another one of the cause for anxiety. Fear conditioning. It's a form of learning in response to fear. So one of the complexities here is that parents who are anxious may behave. They facilitate the development of anxiety in children through parenting style and modeling. So, treatment. For the treatment, I'll not jump into the cognitive behavior therapy or pharmacological therapy. Any patient coming to you with anxiety disorder, the first and foremost thing is detailed assessment. Detailed history taking and examination of the child. Just to rule out whether this is really, whether we are missing something else, like for the medical workup, thyroid, cardiac issues, and medications, like they're sometimes taking cough and cold medications over the counter, excessive use of that, excessive caffeine. So detailed assessment is very important just to know before we say this patient is anxious or before we overdiagnose with some of the disorders. So psychiatric assessment of children and adolescents is very important. So in my clinic, I usually use a rough scale for anxiety, 1 to 10. 10 is extreme anxiety. 1 is your baseline when the last time you never had any anxiety. So that, in subsequent visits, I know that where the anxiety is. Because even sometimes child, if I'm simplifying the question for the child and if I'm saying how much you're worrying today and how much you used to worry in the past, and then he's saying, I'm still nervous, I'm still anxious. So, this rough scale will help us to do what kind of treatment we are providing and where this anxiety symptoms are going. So, Otherwise, other scale that I definitely, once I'm sure that this is anxiety, I use the Children Pediatric Anxiety Rating Scale, that is called as CARS or PARS, Pediatric Anxiety Rating Scale, or Children Anxiety Rating Scale. That's a rough, that's a very small, concise rating scale that I use for kids in our. Sometimes we give this to the parents or to the child if the child is not extremely anxious, and they can fill it themselves, or we sometimes give it to the parent to fill it. So it is online available for free. So that rating scale is very helpful. If screening indicates that there is significant anxiety, then the next step would be the formal evaluation, what type of anxiety it is. Because the treatment differs for all the anxiety. Although this is anxiety, there will be medication, there will be CBT, but the CBT focused, towards a specific disorder, and the medications focused towards specific disorder is different. So that's why the formal evaluation is needed, what type of anxiety disorder it is. Then differential diagnosis, physical symptoms to rule out, as I have mentioned before, medical issues to rule out, hypothyroidism and migraine, asthma, because asthma may get confused with panic attack, and just to rule out whether this is asthma or panic attack. Seizure disorder, there are some kids, I haven't seen any kid delirious, but if they are using any kind of substance abuse, extremely, nowadays marijuana is in the market, and they are just smoking weed and K2 and all that stuff, and they are saying that, oh, it's normal herb, but when they're not using, they are having withdrawals, because brain is, I try to educate my patients that, it's your brain, it's affecting the brain, why you're feeling better. If you're not using this marijuana, how you're gonna feel. So I try to tell that, but I'm doing my part, it's nowhere. So, but they're still using marijuana. If they're not using, they are gonna have withdrawal symptoms that looks like anxiety symptoms. So for lab testing, we try to do the standard lab panel, CBC, PMP, CMP, T4, TSH, just to rule out thyroid, and also urine drug screen, urine analysis, if there is anything else causing any anxiety. Then for treatment, we call it the multimodal treatment approach, because I'm not treating the child alone. I'm working with primary care physician, I'm working with my staff, I'm working with the teacher, I'm working with the parent. So it's a multimodal treatment approach, because otherwise I'm not going to treat. I don't think treating myself alone, the child is going to be how much successful and how much the prognosis will be. So multimodal treatment planning should be according to the severity. So the severity is, if the child is coming with mild anxiety disorders, then cognitive behavior therapy would be the first line. If they are becoming so dysfunctional they cannot even sit and talk to you, then therapy is a waste there. Then we have to start the medication first, and then therapy with medication. So CBT, cognitive behavior therapy, has lots of research shown that CBT has the significant improvement and significant positive results for anxiety. And 5 important components of CBT: psychoeducation with child and parents about the illness. Second is the somatic management. I have a very good example for somatic management, for relaxation and diaphragmatic breathing and self-monitoring of the symptoms. It's very important. When you ask a child, can you show me how you're deep breathing and how you're, so they say, and I try to tell them, and I'm telling you, I did a consult, not for a child, but an 18-year-old pregnant girl in Creighton. I was doing consults, and I was consulted for anxiety disorder for her. And because she wanted the child out, and she doesn't want to go to, this cesarean, and there was no indication that she need to be induced right now. But she was extremely anxious for her first pregnancy. So they called me for anxiety. And then, for immediate anxiety, I was thinking like medication is the only, I never give benzodiazepines to any patients. So I thought what to give to this patient. I started talking to her. I started doing deep breathing. with her, and head to toe muscle relaxation that has research studies have shown that it has positive effect head to toe muscle, and I literally showed her, I can do here later on. I'll show you how to do head to toe relaxation. It helps. It helps me when I'm stressed out in the middle of the clinic, but it helped her so much that after 3 days when she was there, she had this extreme anxiety again, and they were calling me, can you come and give her PR and anxiety, those skills again? So I went there, I talked to her, and I think after a few weeks she delivered, but she was practicing those skills every day. So without medication, that helped. So I think that helps. I don't know, I know research studies are showing it is positive, and positive results have shown, but I think it is. I have tried that with some of my patients, it works. Head to toe muscle relaxation and deep breathing, it helps. And the third is the cognitive restructuring. It's very important, like sometimes challenging the negative feelings of the child, and modifying the negative self-talk. I'm so anxious, I'm going to die. And the child is saying that, then modifying the negative self-talk is very important. Rather than saying this, why don't you say that I'm nervous, but I'm going to be fine at this moment. Why don't you go and, it's okay to be nervous. Sometimes kids, they don't realize that they feel like they're really crazy. And, when they're, right now, there was a patient in inpatient, and I'm going to see her in outpatient too. Actually, she was already too much anxious, and she was so anxious that if somebody will go, nurses or somebody will go too close to her, she had extreme panic attack, and she will start hitting everybody. So, what we did was, all the staff members, nobody will go very close to her. And if she's anxious, she's going to speak loud and say that I'm nervous right now. Can you just leave me alone? And I want to take some time out. I'll just take some space. So that really helped, So I think some of these negative self-talks, we can modify that. That helps. And the exposure methods, that works very well for the obsessive-compulsive kids. And I'm going to talk about obsessive-compulsive kids later on. So imaginal and in vivo exposure, that's a one exposure. I haven't done formal exposure therapy, just with the fear of, I don't know how my patients are going to react. But the psychologists and therapists who work with us, they are doing an excellent job in that. Relapse and prevention plan. It's very important to just, sometimes kids, they say they are feeling better, and they just stop doing the therapy, they just stop doing the medications. But booster sessions are very important, and also continuing coordination care with the school and parents and the family is very important too, so that for the relapse prevention. Now about kids who have problem with anxiety and school refusal. From the CBT and therapy point of view, like if the kids have extreme anxiety, schools nowadays, they are working so well with the providers that they are able to accommodate. Even some schools, they don't have this, they cannot do this IEP, they cannot have much of the staff, they cannot provide special education or any special ed for behaviors, but they can accommodate the child. It's just classroom assistance. If the child is getting anxious, okay, there is someone, our school counselor, they're going to sit with you for some time, and do you want to finish the homework in some other small room? That helps the kids, at least, rather than just him not coming to the school, if school classroom accommodations can be done. So working with the school is very important. So little bit about the obsessive-compulsive disorder. Obsessive-compulsive disorder has 3 components: obsession, anxiety, and compulsions. Obsessions are recurring thoughts and impulses and images which are source of distress and anxiety, but not usual realistic concerns of life. The individual attempts to avoid these thoughts and see them coming from her or himself rather than from outside, such as in psychosis. Very, very, very commonly, obsessive-compulsive disorder, as you mentioned about autism, autistic kids have significant comorbid, OCD, because repeated banging their head and just repeated those stereotypic plays, isolated stereotypic plays, and so it's usually very closely associated with that. Also, obsessive compulsive disorder, if somebody is just saying that these thoughts, psychosis, extremely obsessive compulsive dysfunctional child can look like psychotic kid. They are saying that they are not sleeping and that these thoughts are coming over and over and over. And there was one child who was just scratching his hand all the time. He was feeling like there's something trickling on the skin, and he has to do that. He has to remove it. And when we were asking him, can you see something? What is going on? He said, no, I know there's nothing, but I have to do that. But it was sounding like, he was psychotic. But he was not. He had significant underlying OCD symptoms because that he was having that inappropriate laughing, that his thoughts were coming to his mind, but he was not able to share the thoughts. So he was to stop those thoughts, he was relieving his stress by laughing. And everybody was saying that, oh, he's hearing voices, that's why he's laughing. So, but that was not. And he was telling us, he's not hearing voices. He's so anxious, he cannot talk to anybody. And his mind is just going on and on and on. These thoughts are coming to his, kind of racing thoughts. That to stop those thoughts, he's just relieving his stress by laughing. So, there is very close, we can misdiagnose kids with anxiety disorder easily. So compulsions are recurrent and inappropriate behaviors performed in response to anxiety, distress, resultant of obsessional thinking. As there is normal anxiety, research studies have shown that 75% of the normal general population have some kind of OCD symptoms for sure. So all of us have something, maybe, if we are out of the 75%. At least occur 1 hour a day and interfere with some aspects of functioning or are causes of stress. There are variations in OCD too. In children, there is no requirement that the individual appreciates that thoughts or behaviors are inappropriate. So there is a differentiation between psychosis and OCD. OCD patients will say that they have insight. They know these thoughts are coming and they know they are not there, but they know that they have to do something to relieve the anxiety. But the psychotic patients, they'll say that, these are thoughts, yes, these are real people, that's why I'm doing this. These are real thoughts, that's why I'm doing this. They're talking about me, that's why I'm doing this. I'm trying to, check on the doorknobs because there's someone trying to bang at the door and there's someone outside, but there's no one. But then they try to convince you there's someone. So there is a close, there is a very close, very minor line in between the psychosis and OCD, but OCD patients have insight. Psychotic patients, they don't. And but in children, it's hard to say, when they are doing repeatedly something over and over, whether this is inappropriate or not, it's hard to say. They are not going to differentiate. So in DSM, they say that children may say that, it's inappropriate or not. They may not be able to differentiate it's inappropriate. There are different types, like checking type with obsession around aggression, religion, sexuality, and somatic. Symmetry, obsession and counting, ordering and repetition, compulsion, cleanliness and holding. So about epidemiology, onset usually adolescents or young children, genetic component, connection to Tourette's syndrome. And trichotillomania is also associated with OCD, more commonly in females. I've seen a 3-year-old child referred from a primary care physician with trichotillomania, but she ended up having surgery because she was pulling her hair and she was eating her hair. So she ended up having surgery for the bizarre. Then, as mentioned before, like OCD associated with autism, OCD associated with anorexia nervosa, and psychosis, delusional disorder. So there are different. There's a long list of disorders can be associated when someone is just going over and over the same thoughts and doing over and over the same things. Like anorexia nervosa and bulimia, eating disorder patients, they think they are repeatedly doing exercise, binging, purging. So they are significant OCD. Perfectionists, they are very perfectionist. So anorexia nervosa, eating disorder kids are also having significant OCD symptoms. Prevalence in children is 0.6 to 1%. Male and female rates are roughly equal. Males have earlier onset. Research has shown that symptoms often exist many years before clinical condition is sought. High genetic predisposition leads to early onset and high incidence in monozygotic opposed to dizygotic twins. In research, studies have suggested that problems in functions usually associated with the prefrontal cortex. Functional MRI have shown various subtypes related to different parts of the brain. Basal ganglia is the part of the brain that is associated with aggression and checking. And ventromedial prefrontal cortex have shown cleanliness. So these are done from the research and functional MRI and PET scans done in various institutes, and it's proven. And for treatment again, CBT, as we have mentioned above, about CBT. I'm going to talk about medications for the OCD and other anxiety disorder. But before that, OCD, obsessive compulsive disorder, and obsessive compulsive personality disorder. How to differentiate between the personality disorder and obsessive compulsive disorder. Obsessive compulsive personality disorder, usually it doesn't generate any distress in the patient. They are perfectionist, they were always like that, they are going to be like that. And they don't feel like it's a kind of distress. But in obsessive compulsive disorder, at some point of time, they will, if they are checking on the doorknobs in the middle of the night, and if they're checking on the garage and keys and everything in the middle of the night, disrupting their sleep, and that will interfere with their work and everything. So that dysfunction is present, and they are in distress. They know it's happening. What is happening is wrong. So that is disorder. So that is a close line again, because personality. Then in personality disorder, usually personality disorder is also running in the family. They were raised by their parents like this, So, and also again, OCD disorder have insight, and psychosis. Psychotic patient, they don't have insight. For OCD disorder, there is a very good scale, although it's very lengthy scale, SIBOX we call it, that is Children's Yale Brown Obsessive Compulsive Scale. That's a very long, but if you do that scale, you can easily find out that this patient has obsessive compulsive disorder or not. So I do that for children, and it takes some time, but I try not to do in first session when I'm just trying to relieve his anxiety, So because he's meeting me, I'm stranger to him, he's stranger to me, all of us have anxiety. So I try to do the scale in subsequent session rather than any scale. I try to do in subsequent session, not in the first session, because that is very bothersome for the child to do the scale. So mild to moderate OCD, CBT, severe SSRI and CBT, and severe OCD may need hospitalization. So, about the medications, SSRIs, that is the serotonin, serotonin reuptake inhibitors, are the selective serotonin reuptake inhibitors are the first line for the anxiety disorder. Although first line is the CBT, but from the medication point of view, SSRIs are the first line. But among the first line medication for kids, fluoxetine is proven, FDA approved for anxiety disorders and for depression. So SSRIs, Prozac, 6 years onwards. But sometimes, we are using off-label medications a lot, like Celexa and Lexapro. Celexa I've stopped using a lot because of the high blood pressure, hypertension, and cardiac issues in kids too. So Lexapro, Zoloft, and these are the medications I use for if there is just anxiety disorder. For obsessive compulsive, sertraline and Prozac have shown significant proven benefit, and also fluoxamine. Fluoxamine, it really helps with if you are going to use with Prozac too. But close monitoring is required for side effects. Any SSRIs when we are using, first line black box warning, that is suicidal thoughts. Sometimes kids, they never had suicide thoughts and they were anxious, but now we have started this medication, they are coming up with suicidal thoughts. So it's a black box warning for them. And when we start the medication, initially we always tell them, sometimes the panic attacks, it's a kind of irony that they are coming with so much of nausea and all those symptoms, and then we are giving SSRI and we are telling them it may make your nausea worse, but it causes nausea in the beginning because the way it acts through the stomach, it causes nausea for first few days, but if the nausea is not going away, and you try to take it not empty stomach, because the more empty stomach you're going to take this medication, you'll be more nauseous. And if you're going to take it, for after a few days, if the nausea is not going away, then stop the medication and let us know, so that we can change to the other SSRI. So SSRIs are first line, but also we are using off-label medications. Like I'm from India, and in India we used to use gabapentin, Neurontin, for severe anxiety. So, and we have used in one of the kid here who was, the kid who was not allowing anybody close to her. So we have used gabapentin on her, and she's doing very well right now. And benzodiazepines, no benzodiazepines for kids, because benzodiazepines have high risk of disinhibition. Ativan, Clonopin, or any benzodiazepine. Sometimes when kids are coming to us, they're already on Ativan because for their panic attacks. But they are saying it's not helping, and it's not going to help, because the way benzodiazepines act in the brain, it's going to make them cognitive impaired. The little bit skills of learning the anxiety, dealing with the anxiety, they're not going to learn that. So it makes them cognitively impaired because their brain is still developing. And disinhibition, that irritability, anger, extreme of disinhibition. So we are not doing any favor by giving benzodiazepine to these kids. So education about the medications is very important, before giving any medication, and alternatives, risk, benefits to discuss in detail, and telling the patient, because non-compliance is one thing that we always see, stopping the medication by themselves because now anxiety is gone, then they're coming again because of relapse. So appropriate doses of the medication, when they ask, what dose works best, there is as such no proven study about the exact doses, what's going to work, and for how long it's going to work. They have proven evidence for CBT therapy, like for obsessive compulsive disorder, they need 6 to 12 months, and sometimes 2 to 3 years the therapy session. But for medications, there is no proven studies showing that for how long they need the medication. But close monitoring and follow-up sessions are required in patients. Yes.
Is Paxil a good drug for depression and anxiety for like an 8-year-old?
I don't think so. I don't like Paxil.
You don't?
No, because first it's a SSRI, but there are other SSRIs, good SSRIs. Paxil makes I have seen the kids very slow on Paxil, and so far I don't have good. I have not started, but I have referrals from other providers. When they are on Paxil, I have not seen any positive response on small kids doing good on Paxil.
If this child is on Paxil, and the child seems to be okay until you tell her no about something, and she goes ballistic. I mean, screaming, crying, hitting, stomping. Could it be the medication that's causing a lot of this stuff?
It can be a medication if it's everyday thing. Since the medication is
anytime you tell her no about something, it's just psycho. I mean, I hate to say the word psycho, but she goes from 0 to 60 and just like that, and just going crazy.
If it's just on this medication, and if it's just within the word saying no, I think there is some underlying mood issues going on too. It's not about that this is just anxiety going on or the medication is causing, but there is some underlying mood issues. Mood issues in the sense like impulse control issues, and
now before a child is put on this medication, shouldn't they be tested in some way, rather than just going to the doctor and saying, she's not behaving well, she's not listening at school, so the doctor puts them on medication? Shouldn't they be tested first to see what needs to be Done?
What medication to start, there is no test. But yeah, to rule out the other problems, there is psych testing. We always do psych testing. On all the kids, we always do psych testing. Just to learn different, to know the child more in different parts of the brain, how they are functioning. How is the executive functioning, how is the learning, comprehension in all different parts of the brain. If you're saying no to the child and then then this child doesn't sound to me like very high intellectual functioning kid.
Well, I'm wondering, it's because maybe I'm old-fashioned. I don't feel like it's just because they're not paying attention at school does not mean that they, those letters.
Yeah.
And I think too many children are put on medication that is not warranted without being tested first.
Exactly.
They might be lazy, or they just might be bored. But why put them on medications? And have them on medications until they're 18 and find out they were just normal children. I mean, is that because I'm old-fashioned, or is that?
No.
I think you're too quick to put kids on medications.
I agree to you up to some extent that all kids don't need medications. And testing in the form of whether the screening on as a provider screening. If anybody has never tried any medication and acting out in school all of a sudden, then I don't put the patient on medication. I try to talk to the school. I try to talk to the school counselor. I try to talk to the parents. Because parents, when they are coming with that hope, and that he's acting out, he will be sooner or later they're gonna suspend him from the school. He needs medication. So sometimes that pressure is coming from the parents. But when parents are saying we're just not gonna write out the prescription, because before writing any medication, we have to think. My supervisor, who is also old school, she said that she has never ever seen any true ADHD. She is 65-year-old, and she is saying that she has never seen any ADHD patient in US, true ADHD patient. And right now, what is happening? So many factors to consider. Whether the organic, I always, we do the psych testing. I always try to do, if such a outburst for no reason, and then calming down for after 5 minutes or so, I try to do EEG on this patient. I try to rule out why this patient is behaving like this, and collateral information, expand database as much as possible before putting the patient and slowing him down with the medication. Any other questions?
How about knowing, how about trying to differentiate if there's some, kids, what's normal teenager versus, we have, some of these parents bring them in and they ask, well, I think they're just being a normal teenager, but the teachers think there's more than that going on. I mean, is there a good way to help differentiate that? What's, normal in those kids that are going through those hormonal changes and having problems?
The best thing to do is the level of dysfunctionality. If the child is defiant, if he's saying no to the parents, arguing, annoying them, and doing stuff, coming late home, a few hours late than expected, and doing things that is, we call it normal teenager, so that is normal. But if he's running away from home, not coming home after many days, and using drugs, and then getting suspended, multiple suspensions from the school, and then getting into physical, verbal altercation every day with parents, that is dysfunctionality. So level of dysfunctionality.
My 8-year-old still sleeps with me.
What's that?
My 8-year-old still sleeps with me.
Okay.
I moved to a different room, he follows.
So when was the first time you started educating him, or trying to separating him?
And he screams for hours on it.
So because it's okay to let them scream but before letting them scream, to spend, because that is a part of separation anxiety disorder. So when the child, he needs more attention from you at bedtime. So something that you have already tried or not tried, or having that consistency before the child and all of you go to bed, like soothing music, bedtime stories, and something, bedtime prayers together, and maximum time to spend together before he goes to bed or you go to bed. Once you feel like he's sleepy, let him, and then you can put him in his bed. If he's screaming, after sometimes he's waking up and screaming, let him scream for a few
Because
minutes.
it's not like he's in there alone, his brother sleeps in the same room with him.
So let him scream for some time. It's okay. Because I know as a mom, as a parent, we just feel like going to him and just, but if he's continuously, how to start is he sleeping on the same bed?
They're both on the same bed.
They both of you are in the same bed. So start a little bit exposure with same room, but different place. And then slowly desensitizing him, it's more time spending, like as I said, telling stories and soothing music, and more time, quality time before you go to bed. And then same room, different place. Then little far, and then next room, slowly, that way. Try that.
Thank you.
Any other questions? So what do you think overall? Was it helpful?
It's a lot of information, and I think you're absolutely right. I think it's underdiagnosed, and it's more common than we think, and we just don't think that kids can have this. But the problem is the kids just can't tell us what they're feeling necessarily. And a lot of times what I see is the kids coming in with the tummy aches and the headaches and those types of things that we can't find any reason for, unfortunately. And a lot of times it probably does have to do with some underlying anxiety. And so, good information. Thank you very
Right.
much.
Rewards and positive reinforcement works very well for these kids, who are coming for stomach aches, and like mom and dad, they're gonna give extra cookie before they go to bed, or extra chocolate, or extra toy, and rewards and positive reinforcement works very well for these kids.
Thank you.
Okay, thank you. Thanks a lot.